All right. Good morning, everybody. Thank you so much for joining us today. My name is Megan Smith, and I am the Executive Director of Quality and Training here at Healthcare Resource Group. And we did take the summer off from our free webinar series, but we are back at it again. We're starting with some information on price transparency and the No Surprises Act. And we're just going to dive right in here because we've got quite a bit of content to cover. So what are we going to be talking about today? So we're going to be talking about the CMS regulations. So we're going to do kind of a 50-50 split with our topics. We're going to touch a little bit on some details for price transparency, what's required from CMS, how we can choose some shoppable services, so some best practice on selecting some of those. And then also we're going to dig into the current response for non-compliance. And so there's been some more information sent out just recently on how CMS is responding to organizations that are not complying with price transparency. And then we're going to go into the No Surprises Act, which also lots of things coming out nowadays, things that are changing, more information is coming out daily. So we're going to talk about to date what's been required, and then we're going to talk about some ways that you can prepare for the January 1st go live of the No Surprises Act. So I like this slide, and I think that if you've been in healthcare for any amount of time, these are probably real numbers to you, and they make sense when we have conversations with our patients. But 53% of consumers say they will avoid seeking healthcare because they don't know how much it's going to cost. And this survey, by the way, comes from a Change Healthcare survey related to price transparency. 67% of patients want to shop for healthcare entirely online. So when we think about the internet and the generations, and I'm not gonna pin it just on millennials, because my generation too, we like the internet. We like to be able to get our own information and not have to talk to somebody on the phone. 61% of patients say that their healthcare is more complex than a mortgage payment. So when you think about the position that we're in revenue cycle, it's pretty unique. We know how to navigate the waters for EOBs. We understand terms like coinsurance and deductibles, and it makes sense to us. But for those folks that aren't in the industry, it can be really difficult and it can be challenging. So think about a time that you've been at a party or maybe a family barbecue or a situation with a large group of people, and word gets out that you work for a hospital. And I'm willing to bet most of you have had people come out of the woodwork and just say, hey, so I got this bill, and they want to talk to you about it because it is difficult. It's really difficult to navigate that. And then lastly, 60% of patients have gone to an appointment without even knowing if they could afford it. So it's very real. So jumping into price transparency here. So why are we talking about price transparency? Okay, so I know what you're thinking. Megan, it went live January 1st of this year. We've been talking about it for quite a while. Well, most recent study finds that only or less than 6% of organizations that are required to post their price transparency information are actually in compliance. So this was a survey that was done and actually sent out in Becker's most recently. So it was a survey that was conducted in July, and the time frame that they were looking at was from May 15th to early July, so around the 8th. They analyzed a sample of 500 hospital websites, and this was actually the patientrightsadvocate.org that did this survey, by the way. So they found out that 80% of hospitals did not publish payer-specific negotiated charges. So that may mean that they have price transparency information out there to a certain degree, but they did not put their payer-specific charges on there, their negotiated rates, which means that they're not in compliance, because it is a package deal. You have to have it all out there. 40% of hospitals publish discounted cash prices, and that's it. 52% of hospitals did not publish any negotiated rates at all whatsoever. 19% of hospitals presented 300 shoppable services in a consumer-friendly format, but a significant number of these actually presented incomplete data fields, which ultimately makes them non-compliant. 76% of hospitals published a price estimator tool. And out of these hospitals, which is an option, by the way, you can use a price estimator tool, and we'll get into that in just a little bit. However, 11% of them did not allow users to even see a discounted cash price. And so they had the tool out there, but one of the options was not to see the discounted cash price, which then there again, they're not being compliant with the requirement. So just a little history here. I think we all know this. So there was quite a bit of pushback from several agencies. However, on December 29th of last year, the Federal Appeals Court did rule that the price transparency is going to move forward as planned as of the first of this year. And really that's because those agencies did fail to dispute that the government has legitimate interest in promoting price transparency and lowering healthcare costs. So that was one of the biggest arguments, that the information that were provided and the burden placed on providers to be able to give that information really does not promote price transparency and will not lower the healthcare costs. And I think the largest argument with that, if you've been following any of it, is because we're showing prices on there and negotiated rates, and it is good information to have, but it's not necessarily that patient out of pocket because it doesn't factor in your deductibles, where the patient is at with their deductible, their coinsurance, things of that nature. This is just a flat rate price. And as we all know, all of our benefit levels are different. We all have a different package that is provided to us and different out of pockets. And so that was one of the AHA's biggest arguments. In addition to it was a huge burden to organizations. The charge master requirement, if you think back to a couple of years ago, we were required to put our charge master out there on our websites. And the argument was that this has not actually helped improve the transparency for consumers. So then they entered in the price transparency, which is kind of a charge master on steroids, if you will. And then lastly, in this federal ruling, the evidence was clear. Consumers are frustrated with the status quo. And I think back to that first slide that we looked at where we talked about over half the population that was surveyed said that they really do want to look for their pricing information online. They don't want to have to make phone calls and they don't want to have to jump through a bunch of hoops to get an idea of what their out-of-pocket's going to be. So who's required to do this? So facilities that are licensed as hospitals, and this does include critical access hospitals, are required to comply. Physician services for employed physicians, and honestly, there is no CMS guidance for what an employed physician is, but the IRS will help you out with that. So we'll have a link embedded in our presentation here that we'll send out. Separate offsite locations will also have to include price transparency information if their prices are different. So if there is an offsite location, their prices do differ from the main location, there will need to be an indicator out there and a separate price listing available for that. And this includes individual items, services, and service packages in connection with an inpatient admission or an outpatient department visit if a standard charge has been established. And we'll get into that in just a little bit. Federally owned or operated hospitals, and that's your IHS, your VA, your Department of Defense, they're actually considered in compliance already because their charges are non-negotiable and they are made public in advance. So they are exempt from this requirement. So where does this information have to go? So really we're talking about a couple of data sets. And so what are the requirements from CMS and where we need to have these provided? So they must be displayed prominently on a website. It can't be hidden. They should not have to click through a series of menus to be able to get to this information. It has to be available on the website using a CMS naming convention. So they have provided some tips and tricks for you there, some naming conventions so that it's standardized so that their beneficiaries and consumers can navigate to that information quickly. It must be free of charge, easily accessible, like we mentioned, and you cannot require an account login. It's got to be right there on that front page of the website. Has to be digitally searchable without providing any personal information. So if you are going out there, you're looking through the list of shoppable services, you're trying to find a price for a colonoscopy, for example, what you are not allowed to do is then ask for the patient to log in, create an account, and put in insurance information. Now, if you are going to use a price estimator tool, which we'll get into in just a moment, you are allowed to collect that information, but just if they want to log in and just check prices, you cannot require them to enter that information in. And your data set must be updated on an annual basis, and you have to publish the date that it was last updated so that the public is informed and knows that they're looking at the most current information. So we're talking about data sets here. So what are they? So there's two data sets that must be provided and available. The first is a publicly available all service data set. And then we're going to dig into a lot of those details in just a moment, but it includes 5 elements. So it must be a machine readable charge master listing. And so when I talked about it's like a charge master on steroids, this is it. You have to include your gross charges, your negotiated charges, self-pay walk-in rate. So if there's any discounts or anything like that, you need to include it. And then a minimum and maximum negotiated rate for all payers, okay? The next data set is a shoppable service data set. So there needs to be a list of at least 300 shoppable services, and CMS has provided a list of 70 that will be required. That also needs to be searchable, and it needs to be in a consumer-friendly format. Okay, and just a reminder here that a machine readable format really is just a structured format that can be automatically read and processed by a computer. So think about things like a comma separated or CSV file, a JavaScript object notation, things like that. It does not include a PDF. So when you're looking at the type of data that you're going to save out there, the requirement to stay in compliance must be machine readable. So read up and make sure that your files are saved appropriately. So digging into our all service data set, here's the details. So we mentioned gross charges. So basically, if you have a price for the service, it must be included, and it must be included without any discounted rates. And so if there is a package price that you have on there, the gross charge line item or column, if you will, needs to have the straight gross charges without any discounts. Next, we have our discounted cash price. So this applies to an individual who pays cash or a cash equivalent for any hospital item or service. So back to that package pricing, or if there's anything out of pocket. So a lot of times an insurance company will not cover circumcision for a newborn, for example. That might be a cash price that you have a discount on. So you'd want to list that as well, in addition to what that gross charge is without the discount. So it's two separate items that you'll have to have in there. The payer-specific negotiated rate, so that's the rate or the allowable that you have negotiated through your contracts. You need to have that listed out there as a separate line item, and you do have to have the payer name listed on there. And so if you've got 10 contracts for that circumcision, for example, or we'll use a better example for a colonoscopy that will be covered, you need to have that listed for all 10 of those payers, and it needs to be labeled as such. And so you need to say that this is Premera, this is United Healthcare, and so on. A de-identified minimum negotiated. So this is where your lowest charge, so your lowest allowable that you have in your contract, you need to have that listed out there, and it also needs to provide the payer's name in there so that they know that Premera, for example, has the minimum negotiated rate. And then on the opposite side here, we need to have the maximum negotiated rate, which is the highest allowable that you'll get. And you also need to include your payer name on there. So that's where we're talking about that de-identified. You have to list that information in there. If you don't have it in there, unfortunately, you won't be compliant with this requirement. So all this information needs to be added into that data set. Okay, let's get into some Q&As, and these are really common questions taken directly from some CMS FAQs. So what if the hospital doesn't provide a discounted cash price for any items or services? That's fine. That's absolutely fine. If you don't have a discounted cash price, then you can just post the gross charges, and you don't even have to list that you don't have a cash price. Not a problem. So what if there's an item without an associated HCPCS or CPT code? Do you have to list those? Yes. The long and short of it is, if you have a item or service that you charge for, whether it has a HCPCS or a CPT assigned to it or not, you must put it out here in your file. It has to be in your data set. So if you don't have a HCPCS or CPT code, what CMS is advising is you can use an indicator. So you can choose to put an NA, or you could put a certain indicator on there that you then have a description for over on your website. That's fine too. You just need to keep it consistent. And then down here on that bottom bullet here, there is a table 1, and this is going to be a link that you guys will be able to use when we send out that presentation, in case you don't have or haven't looked at the table 1 from CMS. They give you some examples. So you can use NA, or you can use any other indicator, but you just need to make sure that that's what that's why that's in there. You do not want to leave it blank, okay? All right, so another Q&A here. So what if the hospital hasn't provided the service in the last 12 months? Do we still have to report it? Yes, You do. If it's on your charge master, if it's on your standard charge list, you have to have it in there. So that gives us a good kind of a segue to making sure that our charge master is complete and we have it as updated as possible. So it's one of those tasks, kind of like your reason code mapping for your 835 denials. It's one of those tasks that takes a while. You know you need to do it, and it's a little tedious, to be honest, but it's something that we'll need to do, especially for price transparency, because if you have charges listed on there or standard charges listed, but it's a service that you no longer provide, you definitely don't want to put that out there for the public to see, because then you're going to get a lot of questions. So save yourself the heartache, make sure that you have it cleaned up, and those items can be removed. So then lastly, how should hospitals display charges for service packages that vary based on the severity of illness? So the final rule does not limit hospitals from displaying any additional information. So if you're looking to clarify some additional information like a severity of illness, you can absolutely put that information out there. So CMS doesn't have it so structured that you can't have any additional details. So you can provide a base rate for each severity level within a DRG, or other clarifying information to patients. Just make sure that you have it in standard, kind of, we'll call it layman's terms language, so that the consumer can understand. And keep in mind, you know, as I mentioned when we first started, we're in this industry, so these terms make sense. Patients and consumers are not familiar with these terms, and so try to make it as easy as possible so that you don't end up with a whole bunch of questions, is my 2 cents here. All right, so moving on to the shoppable service data set. So you also have to have this displayed prominently on your publicly available website. So same rules as before, cannot require an account, cannot require a login, no password, things like that. Must be searchable. They need to be able to search this by not only a billing code, so if they end up with a CPT code, but you also have to be able to have it searchable by a description. And so sometimes in our charge masters, well, a lot of times we have kind of a shorthand or we have an abbreviation for what the service is. We're going to want to extend that out a little bit for our price transparency, so that when we do a search, it actually pulls up what that consumer is looking for. They also need to be able to look it up by payer. So kind of going back to that information where we had to include payer for our reimbursement and things like that, you also need to include the payer in your shoppable service data set, okay? A plain language description of each shoppable service. And also the primary code is required. So whatever you use for billing, you want to have in your data set. And then you can use an indicator when one or more of the CMS specified, so that's 70 that are required. If that shoppable service is not offered by the hospital, you can use an indicator. So similar to the other data set we were just talking about, you can use an indicator to say that that's not something that we offer at the hospital. And CMS indicated that NA is perfectly fine, or you can use a different indicator. Just make sure that you define what that indicator means. So popping into a couple of Q&As here. So what is a shoppable service? So really, CMS has defined it as any service that can be scheduled by a healthcare consumer in advance. So some really good examples are joint replacement surgeries, physical therapy, hospital administration of medication, so infusions, flu shots, things like that. So what if a hospital doesn't provide one or more of the 70 CMS required services, or they have less than 300 shoppable services on their charge master just in general? So hospitals must list as many shoppable services as provided, and they need to indicate, just like we mentioned before, if one of their services, or excuse me, if they don't have one of the services from the CMS specified, you do need to have that list indicated on there, so you must have that 70, but it's perfectly fine to put an NA on there. CMS is not asking for you to expand your services so that you do provide all 70 of those required, but you do need to list them in your shoppable service data set, but just put an NA or any other indicator as long as it's clearly defined. So what are those 70 required that I've mentioned a few times? So it consists of 4 standard categories. You've got your E&M services, new patient office visits, office consults, psychotherapy, things like that. And then there's the lab and pathology services. That's the second category. So got a couple of examples here, your basic metabolic metabolic panel, kidney function panel, things like that. Radiology services, that's going to be your CT, MRIs, mammogram, ultrasound, and then medicine and surgery services is the final category on the list here. And that's things like major joint replacement, cervical spine fusion, endoscopy, things like that. So how do we pull those shoppable services? So say you work in an organization and you have over 300, you're pulling your required 70, and then you're left with, 230 more that you have to choose. So how do we do that? So always start with your 70. Okay, and then put an NA in any of those services if it's ones that you do not provide at your organization. And then I would start to look at things that are commonly provided at the hospital. So this is when you want to pull some reports. You want to look at your reports at the claim level is what I would highly recommend, inpatient and outpatient, to track volumes and look at some of the common bundling. So what are the common services that we're seeing patients for that we can put on that shoppable list, okay? Inpatient DRGs, you can take a look at those and you can see how many of those DRGs also include a shoppable service code. You can have that in there. One example is vaginal deliveries. That professional code of the 59400 is also indicated as a shoppable service in the 70 CMS required. So look at some of your inpatient services as well to find what those most common are. And then for outpatient, review your service bundles with labs, any E&M services, and that's where you're going to start putting your list together. And I would imagine for larger organizations, you're probably going to come up with more than 230 in addition to those 70 required. And so that's when you'll want to kind of pare down a little bit. But this is a great place to start on how to select those. Couple things to keep in mind is you want to prepare for some potential data issues. So like I mentioned before, it's good to look at claims activity. It's good to look at volumes. It's also good to look at reimbursement, honestly. If you've got something that's reimbursed really well, then you'd want to put that out there as a shoppable service. But prepare for some potential data issues. So your charge master, like I mentioned before, really should be up to date and complete. It can't be missing any of your NDCs, units of service, drug codes, things like that. Make sure that you have all that information in there, and then it also needs to be updated on a very regular basis, because remember, we do need to put our, it must be updated on an annual basis at least, and we have to put that updated date on there. That's something that we must publish. Your 835 or 837 claim data may be incomplete or not available. So when you sit down to try to pull and look at this information from a reimbursement standpoint, or just a claim volume when you're looking at your 837s, it may be incomplete. So how long have you had 837, 835 files in place? Maybe it hasn't been for the full this full last year. Maybe you don't have all that information uploaded into your system. So in other words, try to prepare early. And I know I'm saying this in October after it went live in January, but there is some work, that we can look at, and then we can always jump on it as soon as possible. So consider payment information may not be available to split. So if you are and split between your professional and your tech, so your 1500 payments and your UB payments, if you have one of those systems that has one account number and it splits those claim types between your pro and your tech, maybe a little difficult unless you have distinct transaction codes to be able to parse out what that payment is. If you're just posting a Blue Cross payment on that account without a unique transaction code that indicates it's for the 1500 versus the UB, then it might be a little tricky if you're looking at reimbursement information. And just generally speaking, it really is good practice to have separate transaction codes. So I would do that as much as possible, and not only for your 1500 and your UB, but I would also do that for financial assistance, prompt pay, things like that. So it's always good to have that separated out as we look at our reimbursement. And then payer contracts may be outdated or not readily available. So remember, we need to put that information in our data set. And so if we don't have a current contract, or maybe our contract doesn't have that much information, or maybe in revenue cycle, I don't have access to contracts. That's something that over in corporate, they handle that. These are things that you need to consider when you're sitting down and getting ready to put together your price transparency files. Okay, all right. So I mentioned it earlier, using a price estimator. CMS says that you can absolutely use a price estimator for as many of the services, the shoppable services, as possible. These are good because the patient can actually get a closer estimate of the amount that they would be obligated to pay. your price estimator must be prominently displayed. So it can't be nested in. So if you're going to use it to take place of your price transparency dataset files, then make sure that you have it front and center. It's got to be front and center, and I would even call it price transparency, and I would put directions and indications all the way up to that so that they know that this is the tool that you're using to satisfy that requirement. You can have the consumers put insurance information in there. This is the one time that they can put that information in there, and in order to get a more specific cost estimation of the service that they're looking for, because it's going to be tied to, so that estimator is going to tap the website, it's going to look directly into their benefits, where they're at with their deductible, and it's going to give them a much closer estimate of what their potential out-of-pocket is. So just make sure, if you want to use that tool, put a lot of instruction, put a lot of marketing around there on your website, because the easier the better, right? And the reason why we want to do that, not only is it good for our patients, but it's also going to help you guys from getting into, and our next little slide here is, this is what CMS is doing about it. So CMS is actively going out to websites, and they're also taking public complaints. And this is how they hear about organizations that are not doing the price transparency. They're not following the guidelines and being compliant. So the first thing that's going to happen is you're going to get a notice. You're going to get a warning letter when you've been found to be non-compliant, and then you're going to have about 3 months to respond. If you do not start your price transparency and become compliant, so maybe you've got your files out there, but you don't have all the information, maybe you don't have it, the payer information listed on there. Okay, you've got 90 days to resolve that issue, and then Medicare is going to go back, or CMS is going to go back and check again. If you still haven't, they're going to give you a second notice, and it's going to be a corrective action plan. You do have 90 days to go through that corrective action plan. And previously they were saying that organizations that were not complying and were issued this second notice put on a corrective action plan, they were also then going to blast your name across their website as somebody that is not being compliant. And we definitely don't want that. Although the last I read, they are holding back on that, and they're actually going to wait to do that in the third notice category. So that would be after they've given organizations an opportunity with their corrective action plan to put the changes in place to become compliant. At that point, if they're still not after 90 days from that corrective action plan, you're going to get your third notice, and CMS is going to issue a monetary penalty, and that's when they're going to put your name on the website. And we definitely don't want that, because that's that negative press, right? So let's talk about the cost, the monetary penalties. So as I mentioned, CMS is going in and they're auditing websites proactively. There are over 6,000 organizations that are required to comply with price transparency across the nation. So it's going to take them a little bit, but they are going in there, and they're also fielding public complaints. There is an opportunity on their website where you can reach them and make that complaint if an organization doesn't have price transparency tools that are front and center, or if they're really difficult to navigate. And that's when CMS is going to take a look. So they have imposed a daily civil monetary penalty for noncompliance, and this is when you get past the action plan section. It's $300 a day for smaller hospitals, and this is the new increase that they just pushed out in the summertime because of the really low compliance rate across the nation. So they increased what these penalties will be. So $300 a day for your smaller hospitals, and those are folks with 30 or less beds. That's what they're indicating as a smaller hospital. For larger hospitals where the bed count is over 30, then you're looking at $10 a bed per day. Now that's not to exceed $5,500, but if you can imagine being a larger facility where you're at that $5,500, say you have a few hundred beds, your full calendar year of noncompliance could be a minimum of $109,000 or could be up to $2 million. Now we're talking about big bucks here. So we want to make sure that we have our things in place as soon as possible, because this is a pretty big penalty. When you are given the notice of the monetary penalty, hospitals do have the right to appeal, but you must request an ALJ hearing within 30 days of the issuance. And so I don't know about you guys, but CMS letters, sometimes they tend to float around. Sometimes it's addressed to an old CEO or CFO, or they just kind of float around all over the place in the business office. So you've got 30 days from the date of that letter to even get a request an ALJ hearing. After that 30 days, there's nothing you can do. You have to pay. So it's really important if you are provided a warning letter that you really follow that closely. So CMS has issued a round of warning letters. They started doing that in April and have continued. So they had sent 165 by this summer. And as of last month, the end of last month, they've sent out 256 warning letters. So that also includes second round warning letters. So your first round warning letters were happening in April, and then some folks actually got a second round warning letter in July and through the summer. So we may start seeing some information out there about hospitals getting that monetary penalty. So we're kind of watching for that. Okay, we are going to shift gears a little bit here, and we're going to talk about the No Surprises Act. So as of last month, CMS has released parts 1 and 2 of the No Surprises Act, and we're expecting at least one more ruling. This additional ruling is expected to add the independent dispute resolution and patient dispute resolution process, so adding a little bit more detail. So basically, the Act bans surprise billing for emergency and out-of-network services at an in-network provider. It also proposes that patient cost sharing cannot be higher than services would be by an in-network physician. Okay? The rule bans surprise billing ancillary services and is always prohibiting out-of-network charges in an in-network facility, like I mentioned. It creates a consent process that will allow patients to waive their balance billing protections and agree to out-of-network charges. So this is going to be similar to an ABN, but the workflow to get to that consent is going to be different. This is going to be a pretty big change for folks. Similar to price transparency, providers must also publicly inform patients about their surprise billing protections, and CMS has defined the qualifying payment amount, which calculates the patient cost sharing, as the issuer's median in-network rate for 2019 and beyond. So they have already indicated what the out-of-network payment is going to be. So wish we would have known about this a few years ago, because then we would have pushed back on a lot of our out-of-network negotiations, those faxes, those, oh, we get the COB, it's usual and customary, because I'm afraid that some of us have set up a precedence of taking reduced payments around the nation with some of the organizations that I've talked to. But let's dig into that a little bit more. I'm trying not to get on a soapbox here, but this is a pretty big change. So I'm glad you guys are logged in today, and try to get as much information. Webinars, there's a ton out there. Try to get as much information about the No Surprises Act as possible. And that's my advice, because the more you know, the more you can be prepared and educate everybody. We should be talking to our front end folks and everybody about this. It's going to be a big change. All right, so what qualifies as surprise billing? So when a patient unknowingly receives care by an out-of-network provider at an in-network facility or in an emergency situation. So if you're traveling somewhere and you need to go to the emergency room, that emergency room is out of your network, and so you cannot be billed for those because it is what would be considered a surprise billing, because you unknowingly received that care out of network. It was an emergency basis. And then also, when we think about being in a in-network provider, or excuse me, facility, sometimes there are out-of-network physicians that have privileges there, and you see them and you were not aware. So for example, a anesthesiologist, if you have lab work done, a few years ago, we had a situation where the lab on site at a hospital I was working for was backlogged. We had too many labs, so we shipped them over to another lab in the state of California, and everything processed, and we were good to go. Patients got bills quite a bit higher because their plan was not in network with the lab that processed in another state. And so that would be considered surprise billing. Air ambulance is also looped into that as well, and there's a little bit of information on there. There is no information on ground transportation at this time, and I'm not sure that we'll see anytime soon because they're focusing a lot on what the independent disputes resolution process is going to be, which is what's going to be coming out with our next final ruling. So a lot of the onus is on the payer when you read through the documentation, which some of us might think, oh, okay, that's great. But for those of us that have worked in revenue cycle, and gosh, this March will be 20 years for me, we know the habits of the payers. We know that when something is given to the payers as their responsibility, that we still need to babysit. We need to monitor that and make sure that things are actually happening. So this is something, you hear the payer provisions. So nearly all private healthcare plans are affected by this. They are not protected under ERISA. This is self-funded. This is private. This is all those guys are required as part of this legislature. ED and air ambulance services must be processed at an in-network rate when the patient is technically out of network. Out-of-network reimbursement, or excuse me, is reimbursed at a qualifying rate, and it must be done without prior authorization. Okay, and the qualifying rate, remember, is that median reimbursement rate, and we'll get into how that's calculated in just in a few slides. But that started back in 2019 is when we're tracking those reimbursement rates. And so, as I mentioned, unfortunately, we may have set up a precedence here. We may have been accepting lower payments this whole time, and unfortunately, that's the information that's going to be used should we go into that dispute resolution workflow. So one really cool thing, and I know we'll read this fourth bullet and it's cool and it sounds great, but we don't know if it's actually going to happen. They're required to do it, but we know that that payments do not actually happen within 30 days from a clean claim. So an interim payment or a notice of denial must be sent by the out-of-network insurance 30 days from receipt of the clean claim. However, the plan can extend up to 15 days for additional information. So if they want records or they want an itemized statement, it sounds good in theory, but we know there's states that currently require this 30 days turnaround payment, and Washington State is one of them, and we still see delays. And so it sounds great, but we'll see what happens. Routine denials are not allowed. So that's something that is specifically spelled out, and they said based on the diagnosis code, based on the the information on the claim, you are not allowed to put in your adjudication system to automatically deny that, so that they can meet that 30-day turnaround time. And then payment is made to the provider, must be made to the provider and not to the patient or subscriber. And so sometimes we see that, a lot of times we see that, especially for an out-of-network situation where the reimbursement is sent directly to the patient. And a lot of times we never see that money, and it's too bad. So one of the requirements is it has to be made to the provider and it cannot go directly to the subscriber. So that's a good thing. I really hope that they change that. Something else that is required by the payer is they have to create what's called an advanced EOB, which is actually pretty cool. But a study that was conducted last July found that 74% of payers are concerned with their ability to actually produce this advanced EOB by the January 1st deadline. So what is this EOB? So they must produce at the request of their subscriber a document that contains all of this information. So it needs to be applicable for in and out of network services. So I'm going to contact my insurance. I've done my shopping around. I'm going to go to X facility. I call my insurance and I go, hey, I'm going to go receive this procedure. I want this done. I need you to tell me, I want an advanced EOB. I want you to tell me what my out of pocket and all my processing is, what's it going to cost me? They have to be able to produce that and turn it around within 24 hours to the patient, or excuse me, to the subscriber. They have to indicate if the facility is a participating provider. So yes, Megan, you said you wanted to go to Hospital X. They are a participating provider, and they need to indicate what the contract rate is. So Hospital X is going to be reimbursed, $500 for this procedure. They also need to have a description on how to find information on in-network providers. And so if it is an out-of-network provider that I want to go see for this procedure because maybe they're the best around here for this particular service, then they'll have to tell me how to find an in-network provider. So that education needs to be provided. And then they need to provide a good faith estimate of providers' billed charges, their allowables, their cost share responsibility, their current standing on their deductibles, as well as their out-of-pocket maximum. So basically the information that we get back when we run our RTE, that's what they have to include on this advanced EOB. So it's really educating that patient and giving them more information. And then also they have to include any applicable disclaimers, which could be also sorts of things. But that's what they have to include on their advanced EOB. And like I mentioned, the payers are sweating it a little bit because they don't think that they're going to be ready to produce this information. Another thing that they need to create is they need to change up their member ID cards, and it needs to include more information about in and out of network. So some cards, and really no two cards are the same. There's all sorts of information out there. A lot of times it contains the co-pays and different subscriber numbers, things like that, but there's not a lot of room on those cards. So here's a challenge for them. So beginning plan years of January 1st of next year, they need to include an in-network deductible, the out-of-network deductible, what the out-of-pocket maximum limit is, that all must be on the card, as well as a assistance number for their member. So they need to be able to have a phone number, a contact number, as well as a website needs to be included, which I'm thinking by and large on the back of the card, most of the time they have that on there. So that shouldn't be too much of a change. But then they also need to include where to find in-network providers, so that there again, it's that education out there. So where can they find an in-network provider? What network are they part of? And here's, a website on how they can locate that information. That needs to be placed on all ID cards for plan years beginning the 1st of next year. So now we get to, as providers, what are we responsible for? So, and this is going to be kind of a requirement standpoint, and then I'm going to talk a little bit about what we should also make sure that we're checking into. So we need to provide a notice to the consumers. It needs to be a single page notice as well as on the website. And this is a notice that indicates what we're doing in terms of a out-of-network processing and the No Surprises Act. So we have to make publicly available the requirements and prohibitions applicable to the provider or facility under the Act, any applicable state balance billing limitations or prohibitions, and how to contact the appropriate state and federal agencies if someone believes that the provider or facility has violated the requirements described in the notice. That all has to be indicated not only on a website, but also as a notice within our facilities. We also have to create a consent form workflow, and I highly recommend doing that. CMS has provided us a standard form. We need to have that consent on file if the patient is in that realm. So say they've been stabilized and we're getting to that point where there are things that could be considered out of network and they could be billed for this, they need that education. They need to have that consent form. This also works for, and that's only for certain services. So I would definitely read that more information a little more thoroughly. Make sure you don't get stuck in a sticky spot in your ED. But this is also really important for our scheduled services for an out-of-network or our scheduled services for a patient that's coming in that may also see an out-of-network provider in network at your hospital or at your clinic. So have that consent workflow in place on the front end and also on the back end there. And then make sure that you implement a workflow to ensure the validity of patient cost share. So for those dates of service where they are processed as out of network, you want to make sure that you have a stopgap in place or you have a workflow in place so that those larger balances don't automatically go to the patient. Now, there are some indications on your 835, there's some reason codes, there's things like that, there's different strategies that you can implement, but you want to make sure that you don't just have the gates open so that these patients get balance billed, because then you'll be found in non-compliance. And you will hear the patients will definitely, this is one of those acts that's out there that more adults know more about than price transparency. A little while ago, I read a statistic that said only less than 10% of American adults actually know what price transparency is, and more than 50% know about surprise billing, because it really affects them. All right, so now let's talk about the reimbursement timeline. And this is where things get a little sticky, and it's frustrating because very small windows to do this. And the reason why is because they don't, the federal government does not want you to initiate an independent dispute resolution process. They don't want you to do it, and the hope is that you're going to privately settle these payments and these negotiations without having to get somebody, an arbitrator, to step in. But take note of these. Make sure that if you have a system with certain indicators or you have an underpayment system, make sure that you're checking in on these quite a bit, and you have these locked in so that you don't lose track. So basically, before initiating the federal independent resolution process, disputing parties must initiate a 30-day open negotiation period, and this is going to determine the payment rate. So basically, you're going to get that response back from the insurance company. They're going to send you their payment based on the median payment amount, and you're either going to agree or disagree, okay? If you disagree, you've got 30 days to go back and do an open negotiation. So that's when you're contacting them, you're having that conversation. Maybe they send over those faxed negotiation letters. That's when you want to jump on top of it, and you want to make sure that you're addressing those right away. So let's see, if a provider wants to initiate the open negotiation period, they have to inform the plan or insurer and send a written notice within 30 days of an initial payment or denial of payment. So the open negotiation period then does extend for 30 business days from the date of the notice. So the parties must exhaust this first box, this option here, the open negotiation period, before initiating the federal IDR process, which is that independent dispute resolution process. So as I mentioned before, the agencies, the federal agencies, do urge that the good faith negotiation works. They don't want you to go into that IDR process. And the agencies do expect that 25% of disputes to be resolved during the open negotiation period. So that's a pretty hefty number. I don't know how much the federal government works with insurance companies, but we'll be optimistic here. So if both parties have not reached their agreement on the out-of-network rate, either party can initiate the federal IDR process, and it has to be within 4 business days. This 4 business day period begins on the 31st day after the start of the open negotiation period and is triggered by a separate notice of IDR initiation that happens from one party to another. So now we're talking about a form. We have to have a form. It has to be after day 31, and you only have 4 business days to do it. Do you hear that clock ticking? This notice must include, among other information, the relevant qualified payment amount, the initiating party's preferred certified IDR entity. Now, there are several steps that you can take, and you can become a certified IDR entity. There is information on the CMS website for those of you folks that want to have an arbitration process and want to get into that business. The qualified IDR items or services at issue. So you have to include in your notice of IDR what the issue is and why you feel that that payment is not sufficient. This notice must also be submitted to federal officials through the federal IDR portal. So there is a portal. Remember, this is a hefty workflow here, on the same day that it's sent to the other party. Okay, so when that is uploaded to the portal, this is going to trigger the federal IDR process. Okay. The parties can agree upon a certified IDR entity within 3 business days of that initiation. So both parties have to agree with that IDR entity, whoever you have chosen. So if no party objects to the initiating party's preferred IDR and there's no conflicts of interest, that entity will serve as the IDR entity. So now we've chosen our IDR, the person that's going to hear all of our information. Now, if the other party, so say on behalf of the hospital, I have initiated that IDR process, I have an entity that I'm choosing. Now, if the other party, so the insurance company that's involved, objects to my preferred IDR entity, they have to explain their objection and propose an alternate IDR entity. The other party then has the option to agree or object. So on behalf of the hospital, I can agree or object, and we can continue to go back and forth for up to 3 business days. Okay, that's it. So after an entity is selected, both parties will have 10 days to submit their offers for payment along with supporting documentation. So this is where you're sending your information to your IDR and you're giving them the reasons why you feel that the payment needs to be, XYZ. The offer must be listed as both a dollar amount and a percentage of the qualifying payment amount, or QPA. Providers and facilities must disclose the size of their practice or facility based on the number of employees and the practice specialty or type. Plans and insurers must disclose their coverage area, relevant geographic area, and whether their coverage is fully insured or self-insured, because remember, ERISA folks have to do this too. This and any other information provided by the parties or is requested by the IDR entity must be submitted through the portal. So you've initiated your IDR, you're pulling together your documentation, you have to have all this documentation included, you'll submit it through the IDR portal. So the No Surprises Act, or NSA, adopts a baseball-style arbitration, which means each party offers a payment amount, and the IDR entity will then select one amount or the other with no ability to split the difference. The decision is binding, although the parties can continue to negotiate or settle. And keep in mind, throughout this entire process, so the 30 days, the 4 days, the 10 days, you're uploading, you can still continue to have that negotiation with the insurance company and try to settle on a price. You can settle on a reimbursement even after you've submitted information to the IDR. So if you've gone this far and then the insurance says, you know what, we're going to give you this and you agree to it, that's totally fine. All right, multiple cases, and this is important, keep this in mind. Multiple cases can be batched together in the IDR process here, but batched cases must involve the same provider or facility, the same insurer, the same or similar medical condition, and must occur within a single 30-day period. So you can't pull claims over the last 6 months and try to throw them together. So there is some guidelines there, but you can batch them. So if you've got several claims that are being processed out of network for a CT scan, for example, and you have maybe 15 cases over the last month or so, same provider, same insurance, you can absolutely batch those together to see if you can get a higher reimbursement for those, which is kind of a similar workflow when we notice that our procedures are either being bulk denied or they're being underpaid. So that's when you work with your provider rep, you batch these together. Same kind of principle here, you can batch them together during the IDR process. So once you've sent all your information in there to the IDR, over the next 30 days, the independent disputes resolution entity will then review all the information, and they're going to issue a binding determination, which is going to select one of the parties' offers as the out-of-network payment. Remember, it's baseball style, and reimbursement is then made. So it's important to note that both parties must pay an administrative fee. So when we think about which claims we want to push through the IDR process, think about you have to pay $50 each is your administrative fee. Both sides have to pay that, and that's going to be the cost for 2022. I would anticipate that increasing. And then also the non-prevailing party. So if they choose the reimbursement offer that the hospital pushed forward through the IDR process, then the payer will have to pay for the certified independent resolution fee. And so these fees can range. And the most recent information that came out from CMS is that these IDR companies will then have to provide information on how much money they're actually gaining each year in these fees. But there is going to be a fee, and I don't know that it's going to be controlled, so some may be higher than others. Okay. So the IDR entity must select one of the parties' offers, as I mentioned, within these 30 business days. And what they're going to do is provide a notice to the parties, and it's going to be a written decision. The written decision will include the entity's underlying rationale. So the IDR will explain why they chose this. And they're also going to include a detailed explanation for all considerations that were relied upon. So basically, if the IDR entity did not choose the offer and went closest to the qualified payment amount, then they will have to include a detailed explanation and any considerations. So once the IDR makes their determination, the party that initiated the IDR cannot initiate a new round of IDR for the same service with the same party for 90 calendar days after the determination was made. So we'll go back to that example of we're bundling together our CT scans for several patients over the last 30 days. They were paid out of network, they were paid too little. If I win, I then win or lose. I then cannot go after that insurance company for more CT scans that were not appropriately paid for another 90 days, and they're calling that the cool-off period. You have to wait, okay? So it says any claims that occur during the lockout period can go to the IDR after the period ends. So it doesn't mean that even though you're waiting 90 days, that doesn't mean that you are just lost with those claims. As you get those claims during that cool-off period, you can absolutely readdress and go into an IDR process with that same payer after the cool-off period. So the hope for the IDR process, the feds will hope this will incentivize payers and providers to resolve the payment disputes in a consistent and efficient manner. The goal is to help hold down health costs and encourage the parties to negotiate, submit reasonable offers, and resolve disputes in a way that does not add any unnecessary time, cost, or complexity to this process. So these goals are more likely to be met given that the IDR entities must select an offer that is closest to the qualified paying amount, which is the median in-network rate that payers pay to the providers, and only deviate. So the IDR can only deviate from that rate, although they are able to, if there is credible information in the need to do so. Okay, so now let's pop into what is that QPA, or qualifying payment amount. So as I mentioned, it's the median in-network rate for 2019 trending forward. So the payments that you have been accepting, the rates that they have been paying, all of that claim data from 2019 forward. So it might be good to pull some reports and take a look at what you can expect so that you can keep an eye on that. So the IDR will factor in the provider level of training, experience, quality and outcomes measurements, teaching status of the hospital, case mix, scope of facility services. On the payer side, the IDR is going to look at the type of contract, the insurance market, geographical region, and if a good faith effort, or if there is a lack of good faith effort, so if you haven't tried to join the network, prior contract rates, and those prior contract rates they're going to look at and factor in is going to be for the last 4 years. And from a patient data service standpoint, they're going to take a look at the acuity and complexity of the services provided when they're looking at that qualifying payment amount. What they cannot consider is usual and customary charge, the billed charge or reimbursement rates of our public payers, and I'm talking about Medicare, Medicaid, TRICARE. Okay, so they cannot look at usual and customary. They can only deviate, as I mentioned, if there is credible information presented. Okay, so if you have indicated, or if you have accepted the median in-network rate for the last couple of years, if you've accepted a lower dollar and you've got increase in prices, and you can really substantiate that this payment amount is not going to work, and you have fought this payment amount for a considerable amount of time, then that could be some credible information that you would want to present to the IDR when you are putting together a higher offer. Okay, so here's our last slide here. So here's your keys to survival. And this is, I wish that I had many more slides to do this, because there's a lot of things that we need to do to prepare. It's going to be a significant workflow. It's going to require a lot of tracking. We see all the time our money is slipping through our fingers through ridiculous denials and underpayments, and we just have more accounts than we have time to look through. But I encourage you guys to really put some processes in place so that you can track this. So focus, be steadfast with your payment offers and negotiations. Put something in your system that will recognize those CARC and RARC codes, those reason codes that say that it was paid at an out-of-network rate. They exist, they're out there, use those to your advantage. Out-of-network payers are persistent. So why do we want to be steadfast? They are very persistent, and their hope is that you're going to give up. Their hope is that they're going to slowly wind you down, and you're going to stop looking at those faxes where they send over, hey, just sign this. We're going to be paying, I'm doing air quotes here, usual and customary for your region. No, don't accept it. Push back. Be that person that always pushes back. Optimize, consider building a specialized team. I think it's gonna be worth it, especially if you're one of those facilities. And this is where the data comes in. How many out-of-network patients do you have? How much money are we talking here? Because it may be enough risk involved that it could pay for a team. And then you could also use that team to do other things too. These folks are gonna be experienced. They're gonna have tools. Make sure that they have tools. Make sure you give them regular training. Maybe this is your robust underpayment team. Maybe this is your robust denial team, and they can also tackle, in addition to making sure you're being reimbursed appropriately out of network and putting together those packets, because it takes a keen eye for that IDR process. Maybe you also want to have them be your higher level denial team. Could be a promotional opportunity for some folks, so that could be a good thing. Make sure you develop your robust response workflow. So thinking back to that really tight timeline that we have, you have to act fast, you have to react fast, and you have to keep track of it. You only have a few days. After day 31, you only have 4 days to say, hey, I'm going to initiate that IDR process. And if you don't initiate that in that time frame, then you have to accept that lower payment from the payers. And then transparent reporting. Can't say enough about that. Get your data. Get your data together, track your data, have it as a dashboard, look at it weekly at least. You've got to have your thumb on what's going on with this. And then IDRs, as a reminder, they can be handled in bundles. So make sure that you optimize that workflow. Pull together with your reports, pull together your data so that you're submitting those things in a bundle. Report, so make sure that you've got both your aggregate data and your results. Include your allowables by your payer, appeal levels, your success rate. How successful are you? Maybe you want to start rewarding some of your employees and giving them a contingency rate there. Hey, if you turn these around, we're going to give you 1% or whatever that is, or bonuses. Get people excited about this because they're going to have to fight for it. It's going to be babysitting. It's going to be a lot of work. And then lastly, implement a robust front-end consent form process. So nothing is tougher on the back end when we get to billing and we're looking at our self-pay balances and we have to check and see if an ABN has been filled out. So what modifiers do I put on there? Can I balance bill the patient? What can I do? Make sure that you have this front end process. Make sure they know what the new cards look like. Make sure they're educated on the No Surprises Act in case the patients come in and they have questions. And then also get that consent form. There's a standardized form that Medicare CMS has pushed out. Get that, use it, train folks, and then you're going to be so much better for it on the back end. It's really going to help you out with that tracking. Okay. All right, so 1 minute over. Tried to squeeze it in a full hour. Thank you everybody for your time today. I hope I gave you some more information that you could think about. Can't say enough about researching on the No Surprises Act. Like I said, it's going to be a big change for all of us in revenue cycles. So get in as much information as possible, and taking that step today to kind of watch me go through some of these things was really good. So thank you so much, and have a great day.